Welcome! Today, we're doing a deep dive on a topic that's, well, incredibly common in pediatrics, but can be surprisingly tricky to manage: urinary incontinence in children. And if you're gearing up for the PEBC MCQ exam, you absolutely have to know this stuff inside and out. We're going to unpack everything: definitions, pharmacology, the whole shebang, giving you those high-yield insights you need to really nail this section. So, what's our game plan? We'll kick things off with the basics. What exactly is incontinence in a child? From there, we'll play detective and investigate the causes, figure out our treatment goals, and explore all the non-drug options first. Then, of course, we'll get into the good stuff, the core pharmacology, starting with desmopressin, then moving to anticholinergics. And we'll wrap it all up with some really crucial pearls on what to do when things don't go as planned. It's the complete clinical picture. All right, before we can even think about treatment, we've got to make sure we're all speaking the same clinical language. So let's lock in the key definitions you'll need. Honestly, getting these terms right is the first most critical step to picking the right management plan. First up, daytime incontinence. Now, the key here is a specific criteria. You've got to know these numbers. We're talking about repeated voiding into clothes at least 2 times a week for 3 straight months in a kid who's 5 years or older. These aren't just random numbers pulled out of a hat. They're the clinical line in the sand that helps us separate a real issue from the occasional accident that's just a normal part of growing up. And now for enuresis, which we all know as bedwetting. Again, notice the frequency, at least twice a week. But look closely at the age difference, because this is a classic exam question. It's considered an issue beyond age 5 for girls, but age 6 for boys. This just reflects the general observation that girls tend to master bladder control a little bit earlier. It's a small detail, but it matters. This next distinction is absolutely crucial. Is it primary or secondary? So if it's primary, the child has never had a consistent dry period of 6 months. This immediately gets you thinking about developmental delays, right? Maturational issues. But if it's secondary, meaning they were totally dry for at least 6 months and then they relapsed, your clinical alarm bells should be ringing. You have to investigate what changed. Was there a new stressor, a UTI? This single piece of information completely changes your entire line of questioning. And we can get even more specific with enuresis. Is it monosymptomatic, meaning it's only bedwetting and nothing else? Or is it non-monosymptomatic, where you're also seeing daytime issues like urgency, frequency, or accidents? This is a fundamental fork in the road. Monosymptomatic points you towards problems with nighttime urine production or waking up. But non-monosymptomatic, that strongly suggests there's an underlying bladder problem, like an overactive bladder, which is going to need a totally different treatment approach. And just so we're all on the same page, this is not some rare problem. We are talking about 10 to 15% of all 5-year-olds. That's a huge number. And it's a vital statistic to have in your back pocket when you're counseling a worried parent. Just normalizing the experience can be a powerful first step in treatment. Okay, so we've defined the what. Now, let's put on our detective hats and figure out the why. What are the underlying causes of all this, and what's the systematic approach we're going to use to investigate them? For daytime wetting, the causes are pretty broad. I like to think of them in 2 main buckets. The most common are the functional causes, things like constipation, where the bowel is physically pressing on the bladder, or behavioral habits, like just holding it in way too long. Then you have the organic causes, which are the red flags we have to rule out, like a UTI or even a structural or neurological problem. Now, when it comes to nighttime wetting, the culprits look a little different. A lot of the time, there's a developmental piece. That brain-bladder connection just isn't fully wired up yet. We're usually looking for 3 main things. 1, does the child just not wake up? 2, are they making way too much urine at night because of a hormone dip? Or 3, is their bladder capacity functionally small? And super important, if the bedwetting is new, we absolutely have to consider secondary causes like sleep apnea or even diabetes. The clinical investigation itself is a pretty straightforward 4-step process, but I want to really stress step 1, the history. More often than not, a really thorough conversation with the family will practically hand you the diagnosis. The physical exam, the voiding diary, and the urinalysis, they're all crucial for confirming your suspicions and ruling out things like infection. But honestly, for most simple cases, this is as far as the workup ever needs to go. This table, which is adapted from the NICE guidelines, is such a fantastic clinical tool. It shows you exactly how the history points directly to the cause. For instance, if a parent tells you their child has one large accident early in the night, your brain should immediately go to nocturnal polyuria. But if they report multiple small accidents throughout the night, you should be thinking overactive bladder. And please always ask about bowel movements. Constipation is a frequent and very treatable co-conspirator here. And this algorithm right here is basically the roadmap for our entire discussion. It shows that whole decision tree, starting with the urinalysis and then branching out based on whether it's daytime versus nighttime issues or primary versus secondary causes. Keep this mental map in your head because we're going to be following these exact pathways as we talk about treatment. Okay, before we jump into any prescriptions, we have to talk about goals and non-pharmacologic strategies. I mean it, this is the foundation of management, and for a lot of kids, it's actually all that's needed. Our goals here are pretty holistic. I mean, of course, we want to rule out anything serious and reduce the number of wet episodes, but goals 3 and 4, that's where pharmacists can make a huge impact. Reassuring the family that this is common and it's treatable, and coaching them on a supportive, non-punitive approach, that is often the single biggest predictor of success. So what does this non-drug foundation actually look like? Well, it's all about behavioral changes. Simple things like sticker charts for positive reinforcement, cutting back on fluids in the evening, and making sure there's one last trip to the bathroom before bed, these can work wonders. And for bedwetting specifically, the enuresis alarm is a really powerful behavioral tool we need to understand. So how do these enuresis alarms actually work? It's basically classical conditioning for the bladder. A little moisture sensor clips right onto the child's underwear, and it triggers an alarm, sound, or vibration at the very first drop of urine. Now here's the key. A parent has to get up, wake the child, and get them to the toilet to finish. Over weeks and weeks, this repetition trains the brain to associate that feeling of a full bladder with waking up. It is super effective, but it requires a huge commitment from the family, and that's a crucial counseling point. All right, let's move into our pharmacologic toolkit, starting with the first-line agent for enuresis that's caused by nocturnal polyuria. And that drug is desmopressin, which is just a synthetic version of our body's own antidiuretic hormone, ADH. Desmopressin comes in 2 main oral forms, a sublingual melt and a standard tablet. And you can see they have different starting doses. The dose can be titrated up for effect, but here's a key clinical pearl for you. Every 3 months, you should plan for a 1-week drug holiday to reassess. A lot of kids simply outgrow the need for it, and the last thing we want is to keep them on a medication they don't need. Okay, listen up because this is the single most important safety message for desmopressin. The risk of hyponatremia is real and it is potentially life-threatening. The drug basically forces the kidneys to hold on to water, so if the child drinks too much, it can lead to water intoxication and seizures. Your counseling has to be crystal clear. Fluids are restricted 1 hour before and for a full 8 hours after the dose. And if the child has any illness with vomiting or diarrhea, you must hold the dose. This is completely non-negotiable. And here's a critical piece of information for your exam and for practice. Health Canada has issued a safety alert, making intranasal desmopressin contraindicated for this indication. Why? Because the absorption was just too unpredictable, and that led to a higher risk of hyponatremia. So for primary nocturnal enuresis, it is oral formulations only. Period. Now, what if the problem isn't making too much urine at night, but an overactive bladder that's just squeezing at all the wrong times? Well, that's where our next class of agents comes in, the anticholinergics. These are our go-to drugs for that detrusor overactivity, which we see all the time in non-monosymptomatic enuresis and daytime urge incontinence. We can break these agents down by their selectivity. You've got your non-selective agent, oxybutynin, which acts on muscarinic receptors all over the body. And that's what leads to those classic side effects, dry mouth, constipation, the works. But then you have the newer, more selective agents, like tolterodine and solifenacin. They primarily target the receptors in the bladder, which means, you guessed it, they're generally much better tolerated. Oxybutynin is really the workhorse non-selective agent, and it's often used first line. It's available in both immediate and extended release forms. An important point is that the extended release versions often give you better efficacy, probably because of more consistent drug levels, and they might even come with fewer side effects. For enuresis, we're typically dosing it at night. The more selective agents, tolterodine and solifenacin, are usually reserved for cases where oxybutynin either doesn't work or just isn't tolerated. And the systematic reviews confirm it. Tolterodine is just as effective as oxybutynin but with a much better side effect profile. Solifenacin is also well tolerated, and it works by increasing the functional capacity of the bladder. Now, you might see tricyclic antidepressants like imipramine mentioned in older textbooks or resources, but for your exam and for modern practice, you need to think of these as a last resort. While they do have some effect, their efficacy is lower than our first-line options, and their safety profile is frankly pretty poor. They have a narrow therapeutic index, and they're cardiotoxic in overdose. That's a massive risk we just don't need to take in kids when we have much better options available. Finally, let's put it all together. What happens when our initial treatments just don't work? We'll cover how to manage relapse and then summarize the most high-yield clinical pearls that are absolutely going to help you on your exam. For patients who fail or relapse after trying just one thing, don't give up. The evidence strongly supports combining therapeutic modalities. Using an aneurisys alarm and desmopressin together can be really effective. And it makes perfect sense, right? The desmopressin reduces the urine volume, which makes it easier for the alarm to successfully condition the child to wake up. And similarly, for those tough cases with signs of an overactive bladder, combining desmopressin with an anticholinergic is the logical next step. This comparison is a critical takeaway for your exam. I like to think of it as the tortoise and the hare scenario. The urinary alarm. That's the tortoise. It's slow, it takes weeks or even months to work, but it offers a more durable cure with a much lower relapse rate. Desmopressin is the hare. It works fast, often on the very first night, but its effect is temporary, and relapse is really common once you stop. This makes it a great band-aid for short-term needs like a sleepover or camp, but it's not a long-term cure. This might be the most important pearl of all. The patient and family factors are just as critical as your drug choice. Success is way more likely in a motivated child with a supportive patient family. On the flip side, if the family is stressed out, intolerant, or the home environment is unstable, treatment is very, very likely to fail. So assessing these psychosocial factors is a core part of your job. So let's wrap this all up with a final thought exercise to really test your understanding. What historical clues would make you consider starting with combination therapy, desmopressin plus an anticholinergic, right from the get-go? Well, the answer lies in finding evidence for both pathologies. You'd be looking for signs of nocturnal polyuria, like those large volume accidents early in the night, combined with signs of an overactive bladder, like daytime urgency and multiple small wettings. This is exactly the kind of clinical reasoning you'll need for your exam.